Welcome to the recorded version of Building Age-Friendly Health Systems, One Community at a Time, from February 20th, 2019, part of the Aging and Disability Business Institute series, a collaboration of N4A and ASA. Okay, we have two presenters joining us here this morning. Lil Bancaro is the Senior Director for the Institute of Healthy Aging at Anne Arundel Medical Center and has more than 3 decades of nursing experience. She holds a master's degree from Notre Dame of Maryland University with a focus on elder care. Lil led the creation of AAMC's Acute Care for the Elderly Unit, which cares for older patients who are average age 81 years old, and was a founder of AAMC's Patient and Family-Centered Care Model. Susan Shelton holds a master's degree in adulthood and aging from the Notre Dame of Maryland University of Baltimore. She is a registered licensed dietitian and has worked in hospital settings and as a private consultant dietitian to several nursing homes and assisted living facilities for 22 years. Sue has been the Assisted Living Program Director at the Anne Arundel County Department of Aging and Disabilities for 4 years and has worked in this program for 12 years. And with that, I would like to turn the floor over to our presenters, Lil and Susan. Welcome.
Oh, thank you for having us today. It's really great to be here. I don't know about you guys, but as you can see, our first picture, this is a picture of our Anne Arundel Medical Center, and it certainly doesn't look like that today. We've got about 4 to 5 inches of snow with some sleet coming, so this is one of our summer pictures that we had. Anne Arundel, let me tell you a little bit about us. We're about 380 beds, nonprofit. We have about 4,000 employees. We have 97,000 ER visits, so we have a very busy ER. We have 27,000 admissions, and out of those admissions, about 40% are 65 and older. So we are definitely looking into an older population in this area. The next thing I just wanted to show you was just how we serve a lot of the counties that surround Anne Arundel. So we're present in multiple different areas, mostly with physical therapy and private physicians' offices and things like that. This is really, Annapolis is a beautiful place. If you ever get a chance, you should come. It's a boating town, sailboats. We're right there by the Naval Academy. It's just about 5 minutes away. So it really is a neat place to come and spend some time with your family, especially if you like to boat and eat seafood for sure. So I know our webinar is all about collaboration and reaching out to each other. And we do a lot of that here at Anne Arundel. We have many partners that we can't do this work without partnering. And, you know, I've been a nurse for a long time, 38 years. And there was a time where we didn't share information or partner with anybody. Everybody kept everything close to themselves, and it's so great that we don't do that anymore and that we can all reach out to each other and learn from each other. And these are just a smidgen of the folks that we reach out to on a regular basis, from our EMS, the Hartford Foundation, IHI, but of course the Department of Aging has been a really great partner with us. And Anne Arundel, over the last year, understanding that our geriatric population was on the increase, that we had to pay more attention, and we decided to look at developing an Institute for Healthy Aging. And I know a lot of organizations are looking to do the same, develop the same kind of programs. And this is really just looking at how do we improve clinical excellence and how we take care of our older population. On this slide, I just wanted to show you the increase in our county. So we live, our hospital is actually in Anne Arundel County. Queen Anne's is our neighboring county, and Prince George's County is our other neighboring county. And you can see the huge increase in population of 65 and older just in the last few years. So we know that this is something we have to start paying attention to, and we've not really done a good job of really looking at the needs of our geriatric patients. So the Johnny Hartford Foundation, they have been fantastic. So about 2 years ago, they came to us, well, actually we came to them and really wanted to be part of this grant program that they were offering to several hospitals to help develop age-friendly prototypes. And the goal of this was to have 20% of all hospitals in the health systems to be age-friendly by 2020. So you're gonna hear a lot of this age-friendly, and that's really the umbrella that all this work falls under, and you'll see that as we go. But we were lucky enough to be able to be with these other hospitals here. We're the first 5. We're pioneer hospitals now. The other hospitals, they're pretty big systems. Anne Arundel was the only single system that was part of this group. So what is an age-friendly system? And it's really very simple. It really is giving the best possible care, not to create any harm, that the patients are satisfied with their care, and that we impact and decrease healthcare costs. And really, and you'll see as I move on, this is not work any different than we're doing now. It's just looking at it differently, because this kind of work is going to be valued to everyone. Patients, family, caregivers, providers, and the overall health system will benefit from this work. So when we started the work with the foundation, we all looked at developing aims, and these were some of the aims that we picked. And some of them were on track, and some of them, I can tell you, in the emergency department, we're struggling a little bit, but we're still staying straight and narrow, and I'm confident we'll get to our goals. So at Anne Arundel, we're very patient-centered, and I just wanted to start with that. We have a large patient-family centered care council. This is Chuck. He's one of our original patient advisors. He was actually, we had a nurses fair, and he kind of sat there and was trying to get the point across that don't do anything to me without talking to me first. And that's kind of been our mantra here, that to include patients and families in everything that we do, from sitting on our quality boards to quality units to ethics committees. So they're very engaged, and they also were very part of this age-friendly work that we've been doing. So this is really the crux of all the age-friendly work. We broke it down into 4 subtitles, and it's what we do every day as health providers. We talk about mentation, we look at mobility, we concentrate on medications, and we want to know what matters to that patient. Where is that personal connection? So the team, when we started, we decided, how are we going to, first we have to educate your staff and caregivers, and so we came up with this little, it's a little laminated card, you know, the size of a calling card, and that's how we started to introduce the concept of the 4Ms. And I will tell you, though, our C-suite is very involved in supporting all this work, so that's been another great piece of this I do want to mention. And I will tell you, like for mentation, even though this was an ACE unit, 3 years ago, we were not really looking at delirium and understanding delirium as well as we should have. We were getting patients out of bed into a chair, which was great, but we really weren't mobilizing them. We weren't really paying attention to medication like we should. So it's been a great education for all of us, and we really think we're making a big difference on how we care for our patients. And we'll talk a little bit more about these later, but these are just some of the things that we've already done so far in a short amount of time. When you have everybody educating and everybody understands this is the right way to take care of patients, you have very little pushback. So you can do lots of cool, fast little experiments and really get stuff implemented pretty quickly. And I just want to show you, this is our team. So the team consists of, we have a pharmacist, our chief nurse, our physician, our staff, physical therapy is on our team. Of course, our patients are always in the middle. The little gentleman in the middle is actually a resident here for like 60 years and was a photographer. We have animated cats up here, and he got to be holding one of those. That's what was important to him that day. And education, when you're starting from basically scratch, education is everything. So we really have taken a lot of credence into educating our staff. We go to nurses' fairs, we go to anything or anybody that'll talk. We give seminars, we have lunch and learns. We have a coffee cart. You can see we put water and cookies, and we actually walk up and down the units, all the acute units, and just to talk and pass out information. And that goes over really well. That's the nursing staff really like that. Great way just to have an informal conversation on what's going on. I do want to show you one of the things that all this work that we're doing needs to somehow get into your EHR. And I'm just kind of giving you a snapshot that we've actually taken some of these 4Ms and started implementing them or having them in our actual documentation, which has been a little of a challenge, but once your IT people get on board and Epic, it runs pretty smoothly. It's things that can be done. So this was one of the things that we've done. We've developed the mobility tech. So without bringing on any FTEs, but just rearranging workloads, we were able to designate a tech every day that their main focus was making sure that people were up and moving with the physical therapy aid, which made a huge difference. Also, we found out we could also use this tech to do some quality measures like do skin checks and Foley checks and things like that. And we've reduced, knock on wood, we have basically no restraint use up here, no hospital-acquired wounds, no Foley infections, and we attribute a lot of that to this work. And mind you, our average age up here is about 85 years old, and we're a 35-bed unit. This is probably one of the funnest things we do. We got together, physical therapy actually came up with this, and it's called Acercise. Actually, my co-presenter, you could see her sitting in the chair there, had her dad up on the unit, and what they do is they bring patients together in a room, and they do exercise to music with a physical therapist. And it's about a 20-minute session, but the great thing about this is the patients sometimes don't start getting, we have to wheel them down there, but after 2 or 3 sessions, some of them are actually walking back to their room, and it's been a great success. And we can't quantify it scientifically, but we see it working every single day. This was another just quick, if you think about it, those little pink pitchers and those plastic cups, when you're 85, 90, 100 years old, those things are so flimsy and they spill. And we decided to go with these cups there that are easy to hold. You could see the volume of water, easy for the patient to drink out of. And we actually can see, we saw like a 60% increase in fluid intake, which is a huge, which really decreases your delirium rates if you're well hydrated. Just a little bit about what we did with pharmacy, and just to show you the impact it can make on your patient satisfaction scores. We had a pharmacist who every time somebody's going home, so a patient's being discharged that day, the pharmacist actually goes to the bedside and has a conversation and goes through all the patient's medications with them. And we went, I don't think you can see it, but we went from a 44% to an 82% rating, and just implementing that. That averaged the pharmacist about 5 patients a day, maybe. So it wasn't too much of a burden. We also went to the bigger boards. As you can see, we had those little tiny boards that I think everybody in the world had at one time. But we really went to these huge boards so patients and families, first of all, could see, and everybody can write on. And we'll talk about that more in a little bit. So next, I'm going to turn you over to my colleague, and she's going to tell you a little bit about my story. Susan?
Thanks, Lil. Hello, everyone. And thank you so much for allowing me to share the My Story tool that we developed with you. If you had a chance to look at the blog, it gave you a good overview of what My Story is. Our assisted living program began working on My Story back in 2016 after my dad was a patient on the ACE unit at Anne Arundel Medical Center. I was very impressed by the way the hospital provided such really good individualized care to his patients. As a county agency, our program monitors the care and services that are provided to about 730 residents who reside in 89 small 4 to 16 bed community-based assisted living homes. So these are residential homes in the community, not like the large for-profit assisted livings. And what we recognized was that in assisted living, sometimes the personal preferences of the resident are not always incorporated into their daily schedule. Caregivers, oftentimes, they're focused more on the care rather than the person receiving the care. So we looked at the small community-based assisted living facilities that we work with and wanted to create something simple that would allow the caregivers to honor and celebrate their residents and yet improve the quality of care being provided. So here is how it all began with my dad. This is my 99-year-old dad, Chet, and it's the front side of the My Story tool. The second photo was taken during his stay at Anne Arundel Medical Center at discharge. The nursing staff at the hospital did such a great job of taking care of him on the ACE unit, and you can see how happy he was not only to go home, but also for the care that he received. Now, inspired by the whiteboards that the hospital had, which Lil showed you in a previous slide, I brought in a copy of the My Story tool that I created for him so that the hospital staff might get to know important information about him right away. So after placing it on the whiteboard in his room, I returned the next day and I found that it was taped to his doorway so that anyone who entered the room could see the information. I found out that the hospital staff, including the nurses and the hospitalists, thought it was very important and helpful to have this information immediately on admission. Now, we know this because patients are arriving at the hospital much sicker than previously, and length of stay has dramatically decreased. So this is my dad's completed My Story form. This is the back side of the side that has the photos. As you can see, the My Story tool is really a simple one-page, two-sided form, and it highlights the personal preferences and the needs of the individual. From the My Story tool, staff could immediately determine my dad's ADL status, which we put all on the bottom of the form, his ability to communicate, and knew that he had difficulty seeing and hearing and disliked being cold and in pain. So the staff at the hospital, at the ACE unit, made sure that he had his glasses on and that they spoke directly facing him. That made a huge difference. They also selected the closed caption feature on his television set so that he could enjoy watching TV, and that relaxed him a lot. He received lots of warm blankets, and the staff made sure that his pain was adequately controlled. Dad enjoyed interacting with the staff about his favorite sports team and time served in World War II. Lil and I shared the idea of promoting My Story as a tool to give the hospital staff immediate information about what matters to that patient on admission from the community, and our collaboration was begun. And it's been great working with Lil in the hospital. The development of My Story is just one of the things that the assisted living program is involved in to help promote an age-friendly community in Anne Arundel County. We are continuously searching for new opportunities and partnerships that will enable us to create an age-friendly community for the older adult residents in our county. Okay, so once we saw the positive impact that my story had on my dad's experience during the hospital stay, our program decided to see how my story could be applied to long-term care, specifically starting in the small assisted living community homes. So in July of 2017, we designed a pilot program to test the My Story tool in small assisted living facilities. Our hope was that we could encourage meaningful engagement between the caregivers and the assisted living residents by having each resident complete their own story. And they were able to do that with the help of staff and family members. Then, if a resident needed to be transported to the hospital, the assisted living facility agreed to send a copy of their My Story for the hospital staff to reference. So here is some information about our study. We worked with 15 of the small assisted living facilities as part of the pilot program. We know the providers of the facility because we work closely with them in our county. So to start with, we met with the management staff to explain how the tool is used and what the concept of patient-centered care is. Then we provided each facility with the blank template and provided technical assistance as needed. The assisted living facilities were given 2 months to complete a My Story tool for each resident and for them to provide feedback based on their experiences. We felt it was really important to get all the staff and residents' feedback. So we included an evaluation form for the caregivers and the family members to fill out and give us feedback and identify any potential issues with My Story. And this was actually a really good thing because we learned a lot of lessons. Here, hold on one moment. I think I missed a slide. Okay, so one significant finding for the My Story tool was the amount of time that it took for the tool to be completed. It was important for us to create a tool that would not be time-consuming because we understood that caregivers don't always have a lot of time, and we wanted the My Story tool to be viewed as a resource and not as a burden for the staff. So we were pleased to hear that the My Story tool was especially helpful to hospital staff who needed to provide care to residents living with dementia. So the My Story tool was actually used as a communication tool and provided useful information on how to reduce anxiety and agitation in these patients when they were transported to the emergency room. We received 2 reports where the information found on the My Story tool helped the hospital staff actually avoid the use of restraints on patients diagnosed with dementia. Okay, so we got some great feedback from caregivers, residents, and family members regarding My Story. We were able to take the feedback that we were given and we created another new form that included information that was actually the most relevant and mattered most to patients and their caregivers. As a result of the feedback that we got from the pilot program, we made some adjustments. And the few of the things we did, the allergies were a huge concern in the medications. Since the homes already send a copy of the PMOF and the medical information, we decided to remove that information because patients would sometimes tell you they're allergic to things when it's not a true allergy. Okay, so we made some adjustments. We changed the form a bit, and then we collaborated with Will and her staff at the hospital to follow residents who were admitted and sent in with My Story. So overall, the residents, the caregivers, and the family members were highly receptive to the My Story tool. The assisted living staff were able to find out information about the residents that they really weren't aware of before. They might have known that a patient liked to listen to music, but they didn't really know what kind of music. So the My Story tool enabled them to know exactly what kind of music they could put on for the resident. Assisted living facilities have to complete a service plan which outlines all the services that they're going to provide for the resident, but a lot of times when we reviewed the service plans, we found that they didn't really include much information about a resident's likes and dislikes. So the staff was actually appreciative of this new way to connect with residents, and in many cases it changed the way they provided care to these residents to better incorporate the things that were noted as important to them on the My Story tool. So here are some additional benefits of using My Story. I think one of the things it's important to note is that the project involved no direct cost. It was really easy to implement, and it engaged staff and was very impactful. Oops. Okay, so we're excited about expanding My Story now that we've seen its success, and we have moved it now into some of the large assisted living facilities as well as home health care, skilled nursing facilities, and rehab facilities. The 4 organizations that you see up on the slide are local, and they're all using My Story, and they have reported that it's really been embraced by the staff that's providing the care. Last year, we were honored to receive the National Mature Media Award for My Story. We continue to work hard, and we promote My Story because we feel it's an easy way to promote age-friendly, person-centered care in the long-term care industry. And these are our current partners and where we hope to expand the My Story tool. Our goal is really to continue to expand it in all assisted living and long-term care facilities. We've been in contact with the various partners and are always looking to establish new partnerships. Through all these partnerships, we've been able to reach about 1,300 residents in the county, which actually exceeded our initial goal of 900. So we're very happy and still continue to work hard. And now I'll return you to Lil for the rest of the presentation.
Thanks, Susan. And what Susan didn't get a chance to tell you was that as these patients are starting to come to us and they have their My Story, we were actually able, there was a combative, confused, demented patient. Because they had their My Story, we understood the underlying issues, and normally that would have been on another floor, that would have been a restraint time. And that patient did not get restraint because of that, because we knew what this patient needed. There was nobody with them because they were coming from an assisted living. And it's just the beginning of the great story that we hope will continue, that My Story can be so impactful. And it comes with trying to figure out, how do the paramedics get it to the ER staff and the ER staff get it up. I mean, it's a process. But when it happens, it's pretty amazing. So our goal with Susan is to make sure that this becomes part of the culture as patients come in, especially through our emergency room. So in all the work that we're doing with age-friendly, to us, the What Matters M is probably the first thing we really worked on. And that's how Susan and I got together, is to really center on the patients and what matters to them. And if you do that, that will drive the plan of care for the patients, in primary care, in the hospital, wherever. And our goal is to eventually push this all through the organization and all to primary cares that we serve. And I just wanted to show you a couple pictures. These are patient advisors. Again, they were involved with My Story. They were involved with everything we do. They were at Nurses Week. They made a What Matters tree. People had to write down what mattered to them, and we had a little tree there for them. Also, inside of the hospital, what are patients? We know that, giving somebody their blood pressure medicine is important, but so to somebody else who lives alone and has no family, that little puppy Gigi is just as important as that blood pressure pill. And to this young lady that just wanted to watch a movie and have some popcorn, but that drove their care for that day, knowing that's how we started their day. We also did a kind of a fun thing that where do you capture everybody as much as you can quickly is outside of your cafeteria. So there actually is a What Matters Day out there. It's June 6th, and we had bunches of stickies, and we offered T-shirts for anybody that would write what matters to them and stick it up on the board. And needless to say, that was a huge success. That day alone, we touched 700 staff and were able to explain a little bit more of the concept of what matters. And they, of course, they love T-shirts around here. I mean, T-shirts are the prize. And these are some of the outcomes that the hospital and the community-based staff really develop personal relationships and connections with the patients and the residents. And patients really feel like they matter, especially when we use Susan's tool. Just think if you come in, you've never been here, and you don't know the nurses, and yet we know all about you. And that's really comforting to the patients. So I want to just tell you a quick story about putting patients in the middle of the center of our care. And what made sense a long time ago doesn't make sense anymore, just like dads not being in the room when their babies are born. We're dealing with patients in their 80s and 90s that have lived together for 60 years. We had this couple gentleman with the long legs who was admitted to ACE, who's had dementia. And his wife was downstairs, had some surgery, and she did not have any dementia. She was his caregiver at the time, and so every day after she was doing well, every day the nurses were running up and down getting these two patients together, and we said, this is crazy. So we brought the two of them back to the ACE and let them be together all day long, and when he was with her, his dementia, he was calm and serene, and it's just another nice story to say that it's what patients need that matters. And they were both able to go home with their daughter and spend the next 2 years actually together at home. So I just thought this would be this is a kind of a cool visual, I think. So when we talk about all the work that all of us are doing, and I know you guys are doing this too, racking your heads with readmissions and length of stays and throughput times from ED to upstairs, does that matter? It does if you look at it in a way like we put it together here. If we are decreasing length of stay, and if we are getting patients in and out of the ER faster, and if our readmissions are down, then we can equate that to years. So in FY17, we were able to figure out for 65 and older, we gave back 9.95 years of not being in the hospital, but being at home with families that really matter, and that's what really matters to them. So that's pretty much all of the work that we've been doing. I think it's just, if you guys have any questions, Richard?
Okay. Thank you very much, Lil, Susan. Lots of great information for us here today. Yes, everyone, it is that time. It's time for the Q&A portion of today's webinar. So if you have any questions for Lil and Susan, now is the time to send them in. And presenters, if you are ready, we will get right to it here. The first question for you, you were talking about it a bit earlier in the hour. Can you talk a little bit more about the Conversation Project?
Yeah, the Conversation Project is actually a workaround trying to get people to pay attention to their advance directives, to start having conversations at the kitchen table about what their wishes are for the rest of their life. And we've kind of, there's actually, Diane Sawyers on 60 Minutes did a great, you can look it up, a great segment on it about having the conversation. Because as many, a lot of you guys that are in the hospital setting understand that to make those decisions in the acute phase is very difficult. It causes moral distress to the staff, and the families are under a lot of stress when there isn't a clear plan for the patient on what their wishes are. So we have a big push here at the hospital to have the conversation project. So we go out to churches and other organizations and as many people as we can, and to run campaigns here within the hospital to our own staff to make sure that people are having the conversation and are getting their advance directives done. And that's what that is all about.
All right, thank you. Next question, presenters here. I know you have an outstanding elective orthopedics program. Have you extended it to fall risk identification and interventions whenever anyone presents with an injury fall?
That is a great question, because that's exactly what we're working on. So we realized, and so again, we've just been into this work about 2 years, and somebody made that same revelation. It's like, okay, if you're coming in for a fall and you've been admitted for a fall, how are we educating you when you leave the house to go home? And we haven't done a very good job of that. And so there's a whole campaign on looking on how we educate patients and how we you know, that should be a red flag to any person on a unit that gets admitted to the floor. Yes, so that is absolutely a focus of ours. And we also are doing some work with our fractured hip team also too, to get more involved in our orthopedics team. But yeah, that's absolutely a great question, and it's something we absolutely identified.
Okay, next question here. For hospital patients, does the intervention include a nutrition assessment and patient's ability to access and prepare food upon discharge?
I think if I can't answer that. Absolutely, we do nutrition assessments. We have our occupational therapists who get consulted that would come in, I think, for a patient if we identified them upon discharge. I am not versed in that to speak to that well, but I feel confident that we are having consults and things like that. But how well or how many, I have no idea.
Okay, we got a couple of similar questions here. I'm just going to kind of combine them together here. Can you or will you share the My Story format? Is it copyrighted, or how could we do that, you know, where we are working?
Yes, I'd be happy to share a presentation packet of the information that we developed for My Story. My email will be available at the end, and you can just certainly email me. I'll be glad to send you out the information. We copyrighted it, and basically we think it will depend on the institution where you use it, whether you're going to use the computer-generated form if your facility is using mainly computers. Here, one of the skilled nursing facilities is pretty much computerized, and they do it by computer. But in our small assisted livings that don't have access to that much technology, they print out the form, and then it can just be used that way. So feel free to use it. Yes, we'd like to get it out there. And if you have any questions, feel free to just give me a call or email me.
Yes, and you can see our presenters' contact information up there on the screen as well as everyone. This information is in the slides if you want to download that, so you don't have to write it down furiously right now. but the contact information is up there on the screen if you would like to get in touch with our presenters about that. Okay, next question here. Presenters, for you, could you explain the readmission graph on slide 45? What is your current readmission rate on your ACE unit?
On the ACE unit, it's probably on ACE, probably about 5%. Last time I remember. Overall, house-wide, it's about 11. And the 5% increase there, a variety of reasons. Volume, and we do have times where months that go by that our readmissions go up, and then other times they go down. Sometimes I wish we had the magic answer for the readmissions, and it usually is because we have such complicated social issues now in the hospital setting than we ever did before. And these are not just older people like your 60s or 80s, but these are people in their 45 and 50s who have substance abuse and mental illness, and so there's a combination of all those things that we're seeing now. But I think we're a perfect hospital, but I didn't want to show a perfect slide.
Okay, thank you very much. Next question. How accepting are for-profit nursing homes and ALFs?
In terms of participating with my story?
Yes, I believe that's the question.
Yes, we've had, well, our one skilled nursing facility that is currently up and running that has 100 people who've completed my story. They've been great about participating with us. The sense is just that it helps make everybody's job a lot easier and really improves the patient satisfaction as well as the satisfaction of the staff. We've not run into any problem negatively about it.
Okay, very good. Thank you. Everybody really likes the My Story format, and this next question is about that. The My Story form that you showed earlier, you mentioned you have changed it up somewhat. Was that the new and improved or the original one? What did you change?
The one that I showed you, my dad's, was the one that is the final version that we are using now. On some of the slides I showed you some of the things that we ended up changing based on responses that we got from the staff. And we removed the medications and the allergies because we just had too many concerns from staff that there would be conflicting information between what the patient thought he was allergic to and whether the medications would be accurate as told to us by the resident. So we totally took that off. We added a lot of information about how the resident communicates because we found it was really important that the ER know that a person coming in who either is aphasic or may have some problem communicating, say because of dementia, that they know that right away. We added marital status and military service in. We put on first language because we found out that that was a big problem. We did add spiritual preference and transferability because when residents from the small community-based homes go to the hospital, they don't know what the baseline is. They see the patient at that time, and it may be that they were able to walk before whatever led them to the hospital. And then we just updated it for ADA compliance so that it is in accordance with the Americans with Disabilities Act. And those were the main revisions that we did, and then we sort of put all the ADL information in the bottom so that that was quick and easy for the staff to see.
Okay, thank you. Yeah, keep the questions coming in, everybody. We've got a lot of good information here for our presenters. Next question here for you, Lil and Sue, are there any evidence-based programs being utilized?
Yeah, so let me go back and because I see another question there about working with academic institutions and the research. So the beauty of this for us, and for anybody out there that is interested, I can give you the information for the Institute for Healthcare Improvement. So the IHI and the John Hartford Foundation teamed up together. So IHI is all about healthcare improvement. And you know that the Hartford Foundation has done tons of work for many years in geriatric care, and they teamed up together. So we have been part of this. So being part of this process, we spent at least once a week, every week, on webinars. We went to seminars. We actually went to Boston every 3 months to meet with some of the most important folks today that are working in geriatrics. Dr. Fick, who does a lot of work with mentation and dementia. Terry Fulmer, who is been embedded. Dr. Fulmer is the president of the Hartford Foundation, who's a geriatric expert who actually started the NICHE program that's all about the care of the elderly. Dr. Tonetti, who is renowned for her work in geriatric mobility. We work with the University of Maryland Pharmacy. So what's been great is we have this unbelievable resource that guides us to use evidence-based practice. They provide us and guide us into the research that's the most recent and up-to-date with tools and medications. And so if anybody is ever interested in doing this work, they actually are looking for other organizations, for other entities, outpatients, and it's called Age-Friendly Health Systems Action Community, where they're looking to solicit people, and there's no charge, but you actually can tap into their resources, into their expertise. They help guide you with data, because the goal is, this goal is not just a goal, it's an actual movement. Everybody's passionate about this work, and we think it should be in everywhere we practice medicine, and caregivers should be afforded the same kind of education. So we want it to be everywhere. So if there's if you'd like to, I can you can give me send me an email. I can give you the information. If you decide that you'd want to be, you can just even get on and listen to the work that they're doing. They've got fantastic resources that you can tap into. Other organizations. We're on a listserv with hospitals, over 120 organizations that we can share information with. Some are clinics, some are, we have very little private physicians' offices that we're looking to really, ask them to help us in this work. Like one of the questions was orthopedics. We have to do more work with that, and there are other organizations that are doing that kind of help guide you to do your next work. So, yes, we're very embedded in evidence-based and research, and we are very lucky to have some of the great people leading us in it.
All right, great. Thank you very much. Next question, presenters. Do you think this has the possibility to evolve into actually repurposing or redesigning space to accommodate my story information? For example, someone who says, I am happiest being outside, and can their room be adjusted for that patient to have a view, natural lighting, nature sounds, etc.? Do you have an example, if so?
Oh, well, absolutely. I mean, well, we're lucky here in our institution. Every room has a window. But there are patients that just want to go outside and have the sun on their face. We will do that. The puppy that you saw, that was a request. People want, yes, I wouldn't, that's the whole purpose. If they want to watch a movie, if they want to watch the ball game, if they want to just Can you take me down to the, I really want to go into the gift shop and buy my grandkid a birthday present. Yes. Could we change the room if it means we could get a cot in there for a family member, or, move something around to get grandchildren in? Yes.
I think one of the important things is that at the hospital really tries to meet whatever a resident's preference is. I can speak to out in the community, and I know that we have used my story with an inpatient hospice unit. The volunteers and the social workers and clergy are involved with my story, and at one hospice, I know the person did want to be outside, and that facility was able to actually move the bed outside for the patient. So it depends, I think, on what the limitations are of the actual facility, but it's pretty limitless as what can be done to help the patient really feel comfortable.
Okay, great. Thank you.
Sorry, and that just all goes to it. We know that if we can grant their wishes is what they need, is how they're going to get better. They're going to get better faster, and their length of stay is going to be less. As far as the acute care goes, we really believe that if we meet these goals of what matters to them, that is just going to just help them get better faster.
Okay, great. Do you have any plans to incorporate home care into the program?
I guess I need some clarification. Home care. Susan, I'm not, is that?
I guess if you're talking about my story and home care, I don't know who put the question in, but if that's the case, we're working with family caregivers right now, and what we're doing is meeting with the support groups and talking to them about my story, and having the caregivers have the opportunity to fill out the My Story form for their loved ones. We are working with a home health agency now that sends its aides in to assist in the home with my story, and the information oftentimes is being used as a good way, an introduction to the client, and it provides an immediate way to kind of touch base with them. Hi, I'm Susan, I'm here to take care of you today. Wow, I see you're from Massachusetts and you love the Red Sox. Gee, they had a great year this year, didn't they? And right away, you can see the connection with the person. We also have talked to adult medical day services about using the My Story tool, and they're in the process of trying to get it started. So I think, yes, we're trying to get it out into home care, and our biggest way to do that really is through caregivers and caregiver support groups.
Okay, great. Next question, presenters. Can you tell us about the support you received to implement this program? Do you work with academic institutions for the research?
Again, yes, we have been, but really the way, what do you want to go there, Susan? It was actually Susan and I having a common interest in the elderly and understanding what's important to them, and a conversation about the work we were doing, and us being engaged and going back to our prospective organizations, letting them know that this was a partnership we were forming. We've got all kinds of support for that. Susan is
absolutely
is part of our age-friendly work. She's known by our CEO, our COO, our CNO. So there wasn't. It was fate, I guess, but it was very easy. There was no. She has an expertise where she is. and we have our expertise and sharing those expertises with each other and the resources. I mean, if it wasn't for her, I think Anne Arundel's really doing a much better job of reaching out to the community to start, in fact, start collaborations of actually having ALF and the nursing homes coming to the hospital quarterly, Susan.
Right.
That and meet with the hospital care managers and some of us to talk about what we can do, what kind of things can we work on with success, what needs to, some of it's just a lot of sharing information. So those are the kinds of things that have come out of this, great community relationships with persons we didn't have before.
Yeah, our collaboration has really been great, and we've received great support, Lil from the hospital and me certainly from my administration in the county here. If the question specifically relates to the first study that we did with the My Story tool, we did not partner with any educational entity for that. We just kind of developed it on our own. We'd love to be able to partner with an academic agency and perhaps get some funds so that we could do, a more controlled study than what we did. But it's interesting because just with what we did, we were certainly able to prove that a simple tool made a big difference.
Mm-hmm.
Okay, great. Next question here. Have you considered engaging area agencies on aging who meet social needs and support caregivers as a partner?
Actually, I'm part of area agency on aging. I'm part of the county organization, and our main organization is N4A. Does that answer the question for that person?
Sounds okay to me.
Yeah, and basically it is Susan and her team and what her auspice of responsibility is. But we do have reached out to AARP. We have to do more, absolutely, and that's what's been so great with partnering with the Department of Aging, to even know the riches out there that we need to do more partnering with.
All right, thank you. Next question. Thank you for the presentation, as a collaboration between your organization and the community-based organizations is admirable. Will there be a push to involve case management organizations that provide care to patients, but not necessarily in LTC centers or assisted living facilities?
I think any organization or facility that's interested in doing My Story would certainly be welcome to try it, and we'd be happy to assist in any way that we could.
Okay. Time for one last quick question here. Can you tell us how you first got involved in age-friendly health systems?
Actually, it was our COO, Malik Joshi, who understood that the Hartford was looking for organizations. We actually had to write a little essay about why we would want to be doing this work, which we did, and they came and interviewed us, and we were picked. So that's how we got started in it.
All right, great, thank you. Well, Lil and Susan, it's just about time for us to wrap up. Unfortunately, we've reached the end of our hour here, but I want to thank you for joining us today for a great presentation. Thank you so much.
Thank you so much. We really enjoyed it, and please feel free to email any questions to me or Susan. Again, thanks for having us.
Yes, thanks very much.